Thank you so much, and welcome, everyone. Thank you for joining NCCOR's Connect and Explore webinar today. I'm with the Coordinating Center for NCCOR, the National Collaborative on Childhood Obesity Research, and I'm going to be moderating the webinar today. And our program today will feature a spotlight segment on new cost-effective and impact estimates for childhood obesity interventions. After the main feature, we'll have a one-on-one segment. That's so that you will have an opportunity to ask our presenter questions. So as you're listening today, please be thinking about the questions that you would like to ask. And then finally, we'll discuss what's ahead for NCCOR in 2016, including 2 studies that will report results in the coming year, and a call for papers on the Youth Energy Expenditure Catalogue and NCCOR's Catalogue of Surveillance Systems. If you have a question for Steve Gortmaker, our speaker today during the presentation, please don't hesitate to write it in the chat box on the right side of your screen. Also, if you need any technical assistance during the webinar, let us know using the same chat box. If you're having trouble logging into the webinar but can hear us on the phone, please email us. And the email address is NCCOR, that's NCCOR, at FHI360.org. NCCOR at FHI360.org. And we'll work with you to resolve the problem and get you back on the webinar. One final but really important technical note. If you've decided to listen to our webinar today using your computer speakers, please turn down or mute your computer microphone. This will greatly reduce the potential for background noise. And since there are a lot of us listening in, that'll be really important. So thank you so much. We'll also be live tweeting during today's webinar. If you're on Twitter or other social media, we encourage you to join the conversation. Please use the hashtag ConnectExplore and follow the Twitter handle at NCCOR here on the screen. Now, our speaker today is Dr. Steven Gortmaker. Dr. Gortmaker is a professor of the Practice of Health Sociology in the Department of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health. He's also director of the Harvard Prevention Research Center and lead investigator of Choices. We're going to hear from Steve today on the latest research from Choices, which is the Childhood Obesity Intervention Cost Effectiveness Study. Steve, there are more than 700 people registered for this webinar today, so there is a lot of interest in your presentation. Thank you for joining us, and I'm going to turn this over to you. Oh, but first, sorry, we have a little poll for our listeners. To the right of your screen and above the chat box, you'll notice a poll with some response options. So you might want to expand your screen so that you can see all of the response options within the poll. If the webinar is not showing on your whole screen, if you will increase the size to fill your screen, you'll be able to see the questions better. So I'll just pause a minute to give you a chance to click and select your response about how familiar you are with today's topic. Okay, I'm seeing a little slowdown in the responses, so I'll just give you one more little bit of time if you haven't answered the question. And we can see, Steve, that about 3/4 of the people on the call are somewhat familiar with the topic, so that's just perfect. And to everyone listening, we hope that after the webinar you'll have a little better understanding and be ready to apply what you'll learn from Steve. All right, so Steve, shall we get started?
Sure. Hi, everybody. And I'd like to get started talking about our project. First, I would like to thank my funders, the JPB Foundation, Robert Wood Johnson Foundation, Donald and Sue Pritzker Nutrition and Fitness Initiative, and the Centers for Disease Control and Prevention. Thanks very much. I'll be walking through our slides rather quickly. Generally, there's not too much on them because I definitely want to leave plenty of time for talking. We're going to talk about how we've been applying our choices model to examine obesity programs and policies high on the national agenda. We do a lot of systematic evidence reviews. We tend to focus on randomized trials, natural experimental and quasi-experimental evaluations for evidence. And we use a microsimulation model to project the impact of both effectiveness, population reach, cost, and cost effectiveness over the next decade. And that's what I'm going to be talking about today. We do have a paper that just came out in Health Affairs that covers a lot of this topic. There's a 65-page appendix with lots of additional detail that you might find interesting, and that's available free online. First, I should mention that I'm part of a big team, and it's a huge team project that we've been working on for about 8 years. My co-principal investigator, Angie Craddock. We have a great modeling team with Claire Wong from Columbia, Michael Long from George Washington University, and then a whole team here, Milton Weinstein, Steve Resch, Zach Ward, Howard Coe, David Hemingway. Great intervention team. We have team leads that have helped us with all these papers, and I just want to make sure that people are aware that it's a big team effort. One issue around obesity in the United States, we know that it's at historically high level. But I think a really important point, and we've seen this through our energy gap modeling work, excess weight accumulates slowly. Children really aren't born with obesity, except rarely, but rather excess weight accumulates slowly. In young children, we see that the energy gap driving the excess weight gain is pretty small. Children haven't gained much excess weight gain yet. By adolescence, this gap has grown because children have been accumulating excess weight for a while, so it now becomes about 200 extra kcals a day. If you wanted to get back to a normal weight, you'd have to change that much. For adults, let's say you have a BMI greater than 35, which is now 14% of that population, the energy gap is really more substantial, an extra 500 kcals a day. So we really focused on prevention. How do you slow the rise of excess weight gain as a preventive strategy? That's where a lot of our work is focused. Of course, obesity is a complex issue. We have multiple risk behaviors shaped by multiple environments. So we really have to think of multiple intervention strategies. And certainly people have tried hundreds of different obesity treatment and prevention initiatives. There's been often very limited evaluative information and not a lot of cost and cost effectiveness information, and that's going to be a big focus today. Our main interest is in finding the childhood obesity prevention policies and programs, as well as treatment programs that will result in the best value for decision makers to implement. So if we look for value for money, value for many. Now, cost effectiveness analysis compares the relative cost and outcomes of 2 or more courses of action. And you can see this little chart here. We really don't want to be in this upper left-hand quarter, higher cost, worse outcomes. Sometimes I feel our health care system fits in this category. We're really interested in those categories where we might spend more money, but at least we're getting a better outcome or particularly that lower right quadrant, lower cost and better outcomes. We think that's ideally where we want to be if we can, but it still costs money to get some results. I know as the father of a couple of twin boys, I keep on thinking that, yeah, but they keep on spending you money, costing you money for quite a while. The choices approach has been to try and identify the best value among more than 40 relevant childhood obesity prevention interventions in the U.S. And we've been looking at a lot of different settings: school, transportation, clinical, community government, and early and out of school care. And we began by working with a national stakeholder group. We began looking at more than 75 different strategies where we looked for evidence of effect. We looked at interest to decision makers. What are people doing? The feasibility of the intervention, potential effects on disparities, sustainability, acceptability, and selected 40 strategies for modeling. We've actually worked through about 43 at this point in time. And for our first results I'm going to talk about here that we talked about in the Health Affairs paper, these are generally focused on nutrition interventions in these 4 different settings here: school, early care and education, community and government, and then clinical treatment. Here are the specifics of the interventions, and again, you can download the supplement to the Health Affairs paper and get lots more detail of how we precisely specified these interventions. Our school meals intervention is just the implementation of the federal nutrition standards in the National School Lunch and Breakfast programs. Smart Snacks, in the same ways, is the implementation of the national USDA Smart Snacks in Schools regulation. And again, I'm talking through these kind of quickly. You can ask detailed questions about the interventions later. The knapsack program is happening all over the country, and the way we modeled this intervention here, or specified this intervention here, is that we required completion of the knapsack program for certification from a state QRIS system for early care and education. Our idea in modeling these interventions and studying them is we asked the question, what would happen if we implemented them nationally? The community and government interventions, we have 3 of them here. One is restaurant menu labeling, which is just the implementation of the federal menu labeling regulations that should go into play at some point in time, hopefully soon. The ad exposure intervention would just eliminate existing federal television advertising tax subsidy for unhealthy foods and beverages targeted at children. I mean, all the advertising, for example, for sugar-sweetened beverages is currently a tax deduction as a regular business expense. Well, that's an example of that. The sugar-sweetened beverage tax would implement at the state level a national sugar-sweetened beverage excise tax of 1 cent per ounce. So those are our interventions, and then we had one that our clinical group thought was a nice benchmark, and that is bariatric surgery. And the intervention here would just be to increase substantially the use of this surgery among children ages 13 to 19 for children who meet the criteria, say a BMI greater than 40. The choices metrics that we look at, and what we're going to be talking about today, are 3 of these right here. We have other metrics, and I can talk about them later. One is just the projected cases of childhood obesity prevented by the intervention in 2025. A second metric, which is a cost-effectiveness metric, would be the healthcare cost savings per dollar invested. How this can happen is if you slow the growth of BMI and obesity, because children or adults with obesity have higher healthcare costs, this can save you money and offset the cost of an intervention. But finally, another cost-effectiveness metric we look at is just the intervention cost per BMI unit reduction per person. you could think of, well, how much would I pay to reduce the BMI unit? The model inputs we use are just the effect of the intervention, expected impact on BMI or energy balance, the reach of the intervention, the number of people affected, and the cost, the resources required to implement. These are the key things we need. In order to develop our evidence, we've developed for each of our interventions very specific logic models that identify all the steps in the intervention between implementation and health outcomes. And then we develop the evidence needed along the pathways. We conduct systematic evidence reviews, for example, to determine the effect of an intervention on BMI or BMI Z-score, for example, with the knapsack intervention, or to look at the effect of a behavioral intervention like changes in sugar-sweetened beverage intake on BMI. And we prioritize in these evidence reviews evidence from experimental, quasi-experimental, or natural experiments. Just to give you an example of the kind of evidence we've reviewed across our 43 interventions, we looked at about 129,000 articles, abstracts of 22,000, reviewed the articles for about 3,700, and really used in our final results about 635 articles. To estimate the reach of intervention, we use a lot of data from the for the specific interventions, and I'll mention a number of the other data sets later in my talk now. For estimating cost of the intervention, we basically just detail all the resources required to implement the intervention. This is the cost of all the activities. We take a modified societal perspective on cost and use standard approaches. It includes all costs regardless of payer and does not include cost of intervention participants' time, like, for example, the children while they participate in an intervention. For our model, we thus first determine these inputs, and then we model the impact of the intervention on subsequent BMI and obesity rates, mortality, and healthcare costs. We have other outcomes we've looked at as well, like qualities, but I won't be discussing those today. We use a microsimulation model. It's kind of like a SimCity type model that models people over the period of 2015 to 2025. We calculate uncertainty intervals using Monte Carlo simulations, and we have 1,000 iterations for a population of 1 million simulated individuals. The model allows us to represent population heterogeneity. We actually make state-specific model estimates. We have a chance to look at intervention effects on disparities over time, and we're really looking at changes in individual level measures and behaviors over time. We base the model. We use data from the U.S. Census and the American Community Survey, the Behavioral Risk Factor Surveillance System, the NHANES surveys, and the National Survey on Children's Health. We use longitudinal data concerning weight and height from 5 different longitudinal studies. So we're actually giving people actual height and weight trajectories over time of real people. Our healthcare cost data come from the Medical Expenditure Panel Survey, smoking initiation and cessation from the National Health Interview Surveys, and mortality rates and BMI from the large NIH ARP Diet and Health Study. So we ground our model in lots of real solid data across the population. And the way it works is we have a baseline scenario. This is how the population tends to grow over time and then eventually die. And we simulate forward that population. And then we have an intervention scenario where an intervention changes this a bit, let's say changes that BMI trajectory. An example of how that works, these are actually the projected trajectories for weight and BMI of a young daughter of one of our programmers. And you can see the uncertainty intervals there. This is kind of a normal growth pattern, and an intervention had slowed the rise of weight and therefore slowed the rise of BMI. That's how it works. So if we think about how we can reduce childhood obesity prevalence, well, you might think of two main approaches. You can treat obesity after onset, or you can prevent excess weight gain through policy and programmatic interventions. And as I mentioned, our clinical stakeholders recommended that we take a look at bariatric surgery. It is an approach that has substantial effects on BMI. We assumed a fourfold increase in adolescents receiving the procedure among 13 to 19-year-olds across the United States. And bariatric surgery, as I said, the evidence reviews indicate it reduces BMI by about 14.5 BMI units. It's very effective in that point, but it does not really substantially reduce obesity prevalence. The children begin with a BMI of about 50, and so they drop to 35 or so. Also, it has a relatively small incidence of all the eligible adolescents, those with a BMI of 40 or greater. Only about 1 in 500 receive the surgery. Finally, it's a bit costly, $1,600 per BMI unit change. So one of the things we've seen, and you'll see in our results in a minute, is that the preventive interventions have smaller effects, but they actually have substantial impact on obesity prevalence because they reach literally millions of people, as opposed to the much smaller numbers reached with this very effective intervention. So here are some results of our modeled interventions. This first metric gives you the estimated cases of childhood obesity prevented in the year 2025. And as you'll see from this bar chart, the school meals intervention has the estimated largest impact. One thing that we should note here is that the school meals also has a relatively large uncertainty around that estimate. Lots of uncertainty. In that sense, the smart snack intervention has much less uncertainty around the estimate and still has prevents a lot of cases of childhood obesity, as does the sugar-sweetened beverage excise tax. And that has a relatively small amount of uncertainty around it also. I did not indicate that on this chart, though. It is in the Health Affairs article in the uncertainty intervals. You'll also notice that the bariatric surgery intervention did not prevent any cases of childhood obesity, although, as I said, it does have a substantial impact on BMI. The next chart gives us some cost-effectiveness metrics. One could call it a return on healthcare or healthcare cost savings per dollar invested. And here, the Smart Snacks intervention, we estimate it saves more than $4.50 for every dollar invested. The restaurant calorie menu labeling also has a positive savings. I should note, though, that this also has a relatively large uncertainty interval. The two interventions with the most substantial healthcare cost savings per dollar invested are the ad exposure intervention and the sugar-sweetened beverage excise tax. These both save more than $30 for every dollar invested. The ad exposure intervention is one that mainly will impact children and adolescents. The sugar-sweetened beverage excise tax, however, has effects on both children and adults, and that's one of the reasons you get this relatively substantial return on investment. For the The final metric here that you might find interesting, the cost per BMI unit reduced. We see here the, again, that high cost of bariatric surgery, $1,600, more than $1,600 per BMI unit change. The sugar-sweetened beverage excise tax, ad exposure, coming in at just a few dollars per BMI unit change, really relatively inexpensive interventions. I guess the same with smart snacks. The knapsack intervention is one that does cost a fair amount per BMI unit change. And by the way, when we evaluate interventions like this with young children, we are looking at BMI Z-score so that age and sex are taken into account. We just find the BMI metric most useful to compare across the different interventions. It's also one of the few interventions, though, that is widely implemented, pretty popular, and we know it has some nice evidence for effect. It just does cost a little more than others. So if I were to summarize some of these results and also other results that we're seeing in the treatment area, it's pretty clear from our look at the treatment and preventive strategies that we can't really treat our way out of the obesity epidemic. The treatment makes a relatively small impact on obesity prevalence. It's kind of too little, too late. What we really want to think about from a societal perspective are preventive strategies that if we really want to make a difference in this epidemic over time. No one prevention strategy will solve the childhood obesity epidemic, so we really have to think about multiple strategies. And if you want immediate healthcare cost savings, you probably want to think about how you can impact both children and adults. And I think here, well, this chart shows you one example of this. These are two interventions that impact both children and adults. And you'll see that the SSB excise tax has a pretty big impact on altering adult obesity, basically because there are just more adults around. And because healthcare costs related to obesity generally rise dramatically and get much higher, particularly at ages 30, 40, 50, and above. That's where a lot of those healthcare cost savings come about among adults. Finally, an additional outcome in both of these, two of the interventions, which we did not take into account in the cost effectiveness of the fact that the SSB tax intervention would also produce an estimated $12.5 billion a year in tax revenue, and the elimination of the tax subsidy would produce about $80 million a year. And finally, we do need to look carefully at how these interventions could have an impact on disparities, and that's another area for study, and I can address some of that if people have questions. So in conclusion, we really do think that policymakers must invest in prevention to reduce childhood obesity. They should invest in those interventions that seem to give you the biggest bang for the buck. Interventions early in the life course, we think, have the best chance of reducing long-term obesity prevalence and related mortality and healthcare costs, which is the only way we're going to get our rates of obesity down in the long run. So that's the Choices Project. We always look forward to talking with folks, and we're very interested in working with potential partners, for example, state health departments, organizations that are looking to think about how they might most cost effectively make a difference.
Well, thank you, Steve. That was terrific, and I think you've given us a starter lesson in how to make some of those decisions, and I'm sure everybody will want to go to Health Affairs and read that too. I'm also sure that there are a lot of questions from this audience, and just a reminder, again, I'm Elaine Arkin with NCCOR, and I'm helping to moderate this question session. So if you have a question for Steve, in this session. If you would type your questions in the chat box located here on the right, we'll be looking for those. Any questions for Dr. Gortmaker, if you would type them in on the right. So as we're waiting for questions in this chat box, Steve, a couple come to mind. And I think, first of all, what kinds of interventions are you planning to study in the future? I noticed you mentioned that you were willing to work with partners. Are you also looking for partners who might have interventions they'd like to include in this modeling?
Well, we've among the 43 interventions we've looked at, today I was mainly talking about nutrition interventions. We've also looked at interventions which were only physical activity interventions. And that's very interesting to look at those. They tend to be a little more expensive as a way to alter your weight, but then physical activity interventions have lots of other positives to them also. I think we also have been looking at interventions that have both nutrition and physical activity components. We're interested in interventions that relate to transport, and I think in our subsequent work we'll be presenting some of those results. We're of course always interested in the potential to model other interventions, and have been looking for partners, particularly at the state level. We're interested in that. We do need evidence to model interventions, and unfortunately, a number of interventions that people may be interested in may not have evidence to support them. But we'd always like to see new evidence.
Yeah, that's not always the easiest thing to do at the implementation level, so my sympathies with that lack of evidence issue. But thanks for reminding us. It's really essential to make sure that we're evidence-based. Another question for you, and that's about both the benefits and disadvantages of modeling these interventions separately versus cumulatively.
Mm-hmm. Well, we discussed that a little bit in the Health Affairs paper. We have modeled these separately because we wanted decision makers to be able to look at the different interventions. As long as the interventions are operating in different arenas, we think that it's probably just fine to say, well, if we get an estimate of an impact of an intervention here, and you also did this other intervention that's targeting a different sector, it's probably pretty reasonable just to add those up. We are modifying our microsimulation model, so we will be able to look at multiple interventions in similar settings and take into account some of the potential relationships between them. So I think that's one way to think about it.
A lot of choices and complexity, that's for sure. Well, one more question that I'm going to insert in here before the one that you'll see on the screen, and you mentioned this, that you might talk about it in this section, and that was the impact on disparities, and you mentioned that you would be willing to go into a little bit more detail about how some interventions could help address disparities.
Mm-hmm. Sure. Well, to the extent that an intervention may make a bigger difference in some part of a population, like with a risk factor. For example, if certain populations of children are watching more television, the idea would be that an intervention that could limit the harmful effects of, let's say, the marketing could have a larger impact on that population. And that would be one example. Another way is if you have an intervention that's maybe delivered to only certain settings. One intervention we've looked at is making physical education more physically active. That's an intervention that requires that children have physical activity or PE or physical education already to receive the intervention. So if you just focus on that intervention alone, it could have the impact of increasing disparities a bit if, let's say, poor children had less access to physical education classes. So those are two examples where you could see reductions or increases in disparities with interventions. And as we move forward with our modeling work, we're going to be looking more carefully to try and model out those impacts on disparities.
So in that first example, you're starting with a look at the population and what kinds of risk situations they're in, and then looking at interventions that specifically address those characteristics? Yes.
So parts of the population, for example, watch more television.
Right.
And if your intervention that restricts the unhealthful or marketing of unhealthful foods and beverages would be expected to have a greater impact on that population.
Oh, that makes sense.
That could reduce some disparities. Mm-hmm.
And so you're looking, though, both at reducing disparities and unintentional effects and increasing disparities as well. Just
right.
Also important.
I think that's a better way of saying it. Yes.
Let's see. I think there might be another one here. So in addition to other kinds of interventions, are there other measures of impact or cost effectiveness you plan to include in future studies?
Mm-hmm. We have used a range of cost effectiveness metrics. I mentioned our healthcare cost savings per dollar spent. We've looked at the cost per a reduction in rate and prevalence of childhood obesity as an outcome. We've looked at the cost of an additional, reducing an additional year with obesity. We have looked at longer-term measures in our studies, particularly with interventions that impact both children and adults. One metric that some people have used in cost-effectiveness studies would be disability-adjusted life years. Another metric would be just life years or quality-adjusted life years. And we have used those. For interventions focused on children, however, mortality rates among children are very low, which is good. But you don't see much effect on mortality rates until a population reaches maybe age 35 and 40 and above. And so you have to assume very long-term effects of interventions to be looking at those type of metrics if you're only focusing on childhood obesity interventions. For our sugar-sweetened beverage excise tax intervention, we do see very substantial effects on quality-adjusted life years pretty quickly in just a few years. And that's an example of an intervention that, of course, targets not only children and adolescents, but adults. And so those types of mortality measures we can use over a period of time.
So that's a good example of how you really have to tailor the measures for different populations, for children versus adults. It's a really important consideration. So we are hearing about other measures, about other kinds of interventions you're going to study. What is the timeline for when we might hear from you next about some of these other kinds of interventions?
We should have a report out about the physical activity interventions. I think Angie Craddock will be talking about that at Active Living Research. And we have a range of other studies coming out probably right after that.
So soon?
Soon, yes.
Oh, that's great. A couple of other questions from the audience. Here's a specific one. Does the article rate the 43 interventions so that we'd have some idea about what you found that worked best? Great question.
Well, what the article I'm talking about, the one in Health Affairs, does talk about these 7 interventions. And I have just given you metrics to help you think about, quote unquote, what worked best. I think it's a good question. And as you probably saw here with just these 3 metrics, these different interventions have different kinds of effects in terms of population impact, cases of obesity prevented, the healthcare cost return on investment that varies across these, and we'll also see that our other metrics vary as well. The cost of the intervention, the total cost of the intervention. So I think decision makers really need, I think, to become more used to not just asking the single question, it doesn't make a difference, but rather start to ask the question, does it make a difference at the population level? What's the relative cost effectiveness of this intervention compared to others? What's the population impact of this intervention? And then I think with these additional questions we've alluded to, like what is the impact on disparities? Is it a sustainable intervention? I mean, is it feasible? I mean, I think those different metrics are important to think about what's the best.
And some of those are the very criteria that you were using to look at the interventions in the beginning. So that makes a lot of sense. So you were talking about cost effectiveness as one of the outcomes that policymakers might consider. So when agencies or communities think about interventions, are they paying attention to cost and cost effectiveness now?
Usually, a lot of agencies, it depends on the agencies. For example, state health departments, city health departments, usually think about the costing of interventions, not necessarily from the way we've been costing them out, but certainly from the perspective of if they have to pay for certain interventions, they think about what it means for their costs, at least from the agency perspective. I think it's an area that's starting to gain more interest among researchers at the CDC, certainly, the USDA and NIH, and I think this notion of best value for money is one that we have to be thinking about at the societal level. So I think sometimes yes, but very often no. And I've seen a lot of just ignoring the cost as interventions are developed. And one thing we found is that it's very expensive to estimate the effectiveness of interventions, particularly if you want to do a really good job and try and design something like a randomized trial or a natural experimental evaluation design. It usually costs a lot of money. We find it's much less expensive to collect the cost data for a lot of the interventions we're talking about here, because a lot of the costs really involve the time of people, and it's not that difficult to come up with reasonable estimates of those costs. So it's a very doable thing. We've been developing a whole manual for how to do this, like with examples, and I think our experience has convinced us that it's something that people should be doing regularly because it just doesn't cost that much. It's actually pretty cost effective as a research strategy.
So that's great that you are putting together a manual. Is that something that's going to be available soon?
Yeah, we're putting together an article with examples, and we'll attach the manual.
So there are a number of questions that have come in about specific programs. For example, what are the components for smart snacks, and have you looked at fruit and vegetable prescription programs? Have you looked at WIC and early childhood interventions, and where can we find examples of the 43 interventions? Are most of these questions covered in the Health Affairs article?
Yeah, the Health Affairs article has a 65-page appendix, and so the details of the Smart Snacks intervention are there, for example. We have been looking at WIC package and changes in WIC in another study. We haven't put together, though, all the 43 interventions. That'll have to wait as we go through our process of getting papers accepted, rejected, reviewed, renewed, et cetera. It just takes a while.
Right. Well, you can see there's a lot of interest, and we want it, and we want it now. So we'll all be looking for it. And one final question from the audience. I know that there are a lot of others, but we're running out of time. This has been an active group. And that is with, I'm just trying to find it again. So and I'm going to quote it, with funding constantly being cut in public health, has research conducted by choices increased buy-in on the importance of prevention?
I would hope we could increase buy-in. I think some of our findings even surprised me. And I think once you start to combine the effect with reach and cost, you start to find examples of preventive strategies that are just very compelling, going, why aren't we doing this? Why is this not a focus of attention? I think we want cost-effective prevention, absolutely. And I think that's kind of the key, particularly if we can show ways to better spend our public health dollars. I've been, of course, struck by a lot of people of how there's just been a decline in a focus on public health interventions, and state health departments, I think, have been struggling, for example. And I think it's terrible what's been happening, but I think one way to start to turn that around is to show that, in fact, there are some very good value propositions out there. And I think that this type of approach can help in that.
So you can make a compelling case, given the data that you're putting together.
Mm-hmm.
This is terrific, and you could tell, because I was having trouble finding that last question, it was because there were so many questions coming in. So there's a great deal of interest, and a lot of people are asking about access to the slides and to the webinar itself. And just to let everyone know, we're keeping track and posting answers to your questions. They'll be on NCCOR's website following today's webinar, and I'm sorry we couldn't get to all of the many questions. And in addition, the webinar will be posted in the slides, so that if you want to share them with coworkers, then we would be delighted to have you do that. And again, they can find those on the NCCOR website. So, Dr. Gortmaker, Steve, it's been great to have you here, and great that so many people have been able to hear this. And it's very exciting to know that that prevention can work to prevent childhood obesity, that it can be cost effective, and love your slides about, but there's no one strategy, no one intervention. You showed us that they're quite a different, just the examples you gave us were quite different, both in the design and in differential impact. So really great presentation, And we all look forward to seeing the health fairs article as well. Thank you, Steve.
Great. Thank you.
And so we just have a few remaining minutes. We'd like to talk about two ways that NCCOR is advancing research in childhood obesity. Steve was pointing out how important research is for decision making, particularly with limited resources available. So NCCOR has a number of projects that will be sharing results in the coming year. First, the Healthy Communities Study, which is examining 130 demographically diverse communities with an estimated 5,000 children and their parents to explore promising programs and policies designed to address local childhood obesity rates. It's primarily funded by the National Institutes of Health with support from NCCOR's other funders as well. And then we'll also be seeing results coming from the Childhood Obesity Declines Project, also an NCCOR project funded by Robert Wood Johnson Foundation and conducted by ICF International, and again, in collaboration with the other NCCOR partners. So you will be hearing more about both of these on the NCCOR website, and I hope you are on our listservs as well. The Obesity Declines Project is exploring community perceptions of potential drivers of reported declines in childhood obesity, particularly those that have influenced disparities. And you can see here on the screen, this is sort of a deeper dive into a limited number of communities, including Anchorage, New York City, Granville County, North Carolina, and Philadelphia. So quite a diverse set of communities. And stay tuned to NCCOR for more on both of these. And again, if you aren't signed up, we hope that you will sign up on the website. Additional news, there's a call for papers for NCCOR's Youth Energy Expenditure Work Group, which is developing a youth compendium of physical activity measures. It's a comprehensive and standardized list of the measured energy cost of a wide variety of youth activities. It's really important because researchers in the past have had to use adult measures, and so obviously it's really important that we have this standardized list that are more specific to youth, both because of age and the difference in the kind of activities that they are involved in. So NCCOR invites investigators to contribute original research articles that will inform the development of the compendium. Those articles will be published in a special open access supplemental issue of the Journal of Physical Activity and Health next year. You can see that there is a rapidly approaching deadline for articles, and there is a website here listed for more information, and the link will also appear shortly within the chat box on the screen, so that you have continuing access to that as I go through the slides. And then just a moment about a number of tools that NCCOR has for researchers. One is the Catalogue of Surveillance Systems, which provides a one-stop access to more than 100 publicly available data sources relevant to childhood obesity research. The datasets in the catalog include information on obesity-related health behaviors, on outcomes and determinants and policies, and environmental factors. The NCCOR is updating the catalog and is seeking recommendations for datasets to be considered for inclusion in the updated version. So if you have suggestions, please visit the address here on the screen, www.ncor.org/ncor-tools catalog feedback. So that's, again, should be listed, team, in the discussion section so people can find both of those websites. Jordan? If you have any additional questions about NCCOR, the things that the collaborative is doing or upcoming activities, please email the coordinating center at NCCOR, NCCOR at FHI360.org. And again, we're just about out of time, but I want to note that this will be archived. And if you go to the NCCOR website, you will see there's a resources tab on the home page. And then when you pull down the resources tab, then you will see NCCOR webinars. And you can find it under that list of webinars. So you can also stay connected with us by following NCCOR on Twitter and LinkedIn, visiting the NCCOR blog, and signing up for our monthly e-newsletter. So again, we invite you to visit www.ncor.org to engage with us. And finally, thank you. Thanks again, Steve, and to everyone who stayed with us today. Before you sign off, please take a moment to complete our brief 6-question survey. Your responses will really help us to shape future webinars and make sure that we make the best use of your valuable time. So we're going to switch over to that feedback form now, and you can write in your input directly on the screen and hit submit. It takes about 30 seconds. So again, thanks for joining us. Thank you, Steve, and I hope everyone has a great afternoon.
Thank you, ladies and gentlemen.